Did you know that the United States uses the DSM-5 diagnostic criteria for assessing for ADHD and ADD, while in Europe they use a much stricter ICD-10 criteria, which makes their national average less than 1%, compared to the 8 to 12% in the United States.
Hi, this is Dr. Jonathan Youssef, Networking for Your Optimal Health. Today's topic is going to be about attention deficit, and with me now is Nikki from South University. She's a PA student, and she wants to talk about attention deficit. So this topic I already discussed a couple of times, but I really think that she's got some insight and some information that will be new to us. So without further introduction, here is Nikki.
Hello, my name's Nikki. Okay, so getting started, ADHD and ADD are defined by attention deficit disorder and attention deficit with hyperactivity. To meet the diagnostic criteria, we as physicians and PAs and nurse practitioners all use the DSM-5 criteria, which splits into inattentive type without hyperactivity and deficit with hyperactivity. To fall into the inattentive type, you have to meet at least 6 of the following criteria to make the diagnosis, such as often fails to give close attention to detail or makes careless mistakes in schoolwork, work, and other activities, often has difficulty sustaining attention in tasks or play activities, often does not seem to listen to what is being said, often does not follow through on instructions or fails to finish schoolwork, chores, or duties in the workplace, often have difficulty understanding and organizing tasks and activities, often avoids or strongly dislikes tasks such as schoolwork or homework that can require sustained mental effort, often loses things necessary for the tasks or activities such as assignments, schoolwork, pencils, books, and for the adults it can be cell phones, car keys, often easily distracted by extraneous stimuli, and often forgetful in daily activities.
So I noticed that that for the sort of inattentive type, you mentioned the criteria based on a DSM-5, and I know that we talked about that just a few minutes ago, that the DSM-5 was the updated from the DSM-4, which was essentially being used by psychologists and psychiatrists to help organize and diagnose, put a criteria in place for the diagnosis of patients. So this is kind of a stepwise order to think about patients with attention deficit and how to organize it in your mind. What are some of the criteria? And a lot of these symptoms, would you say that they're very common though in young kids? How do they distinguish sort of between the type of inattentive problems that they would have versus what might be like attention deficit? Is there anything that kind of stands out that might not be sort of what we think is normal behavior for a young child?
One of the biggest differences between just childhood inattentive and actual diagnosis of ADD or ADHD is the symptoms have to be present in more than one social setting. So they have to exhibit those symptoms of inattentiveness at school, at home, in daycare, in social settings with other children.
Sure. Is it usually girls that have more inattentive rather than the hyperactive impulsive, or is it boys, or is there a distinction between gender between those two?
There is a 2-to-1 ratio where it is much more common in males than females. Males tend to be more hyperactive, and the girls can tend to be more the inattentive type.
Excellent. I know the next topic will be your hyperactive impulsive.
Yes. So to make the diagnosis of hyperactivity, so ADHD, the patient has to meet 6 of the following criteria, which include fidgeting with or tapping hands and feet, squirming in the seats, leaving the seat in the classroom or in other social settings when they're expected to be remain seating, running about or climbing excessively in situations where the behavior is deemed inappropriate, difficulty playing or engaging in leisure activities quietly, unable to be or uncomfortable being still for extended periods of time, excessive talking, blurting out answers to questions before the question has been completed, difficulty waiting in lines or waiting their turn with play and games, or interrupting or intruding on others. So that can be interrupting one's speak, or it can be like intrusive fidgeting.
Yes, it took me a lot of power to not interrupt you right now. So, no, I agree. Definitely, that's one of the things that we see in our patients. We oftentimes see patients actively doing that in the waiting room or during their office visits, and it helps to make sure that that their diagnosis is correct. And so you do see a lot of that in adults as well as children. But yeah, I agree with you that that's a very telltale sign. Fidgeting, typically interruptions, going from one task to another, squirming, unable to focus. And I think it makes for a very difficult interaction socially with patients. So when you're faced with someone with attention deficit and they seem short or not focusing on your topics or discussing things or changing topics midway, I can't get too upset with it, because you have to understand that might be part of the medical condition, and being patient and understanding and working with them to find the right solution is the key. So perfect. What's next on your agenda?
Oh, yes. So some further criteria for diagnosis is none of these symptoms can be brought on by other types of mental or psychological disorders. So there can't be any early signs of a schizophrenia, a bipolar disorder, even like an oppositional defiance in children. That would kind of exclude the diagnosis of ADD or ADHD, because those symptoms of inactivity or hyperactivity could be attributed to the other disorder. One criteria that is on the list is that they're diagnosed no later than the age of 12. However, that is frequently debated. I recently saw some statistics that say that the symptoms can wax and wane throughout life. So it's very common to have a childhood diagnosis missed, and then the symptoms can reemerge in adulthood in a strict office setting. It can kind of magnify potential symptoms.
I've had a few patients that came in and told me that that they had symptoms since they were very young, and that their parents didn't want to put them on medication because there was a stigma in the 60s, 70s, and maybe 80s that was sort of anti-stimulants because of all of the drug use in the 60s. But so yeah, I do think that there's still the stigma of not using medication. Or even a young patient came in and she was more concerned about others knowing that she's been on medication for attention deficit, even though it helped her a great deal. So I agree there is a delay in diagnosis, possibly because the treatment is usually a stimulant in most cases, but in some cases it's not. But in that case, people are anti-medication for it.
Yeah. These days, which we'll get into that more, there's lots of other treatment options that are not necessarily stimulant medications. So that can help kind of remove some of the stigma associated.
I also think that with the diagnosis, this is one of the hardest parts, is that people want to find a diagnosis not just by answering a few questions, but almost a subjective evaluation or an objective evaluation of it. In other words, that, is there like a written test or a tool that you can use? But oftentimes that these are not available for everybody to use. There's a software program is what is one of the tests that you could do, but it's not an easily available product, and it has to be run by somebody who's trained in that.
Yeah, the software program that you were mentioning is called the Continuous Performance Test, which is the computer-based. You answer a series of questions. They monitor your eye movement on the screen to see if you're easily distracted. And then that's something that's usually performed on adults. For children, there are a series of questionnaires that can be sent home to be evaluated by, depending on the age, the patient, the parent, student, teachers, and other adults that work closely with them. Those tests are the Connors Parent-Teacher Rating Scale and the Berkeley Home Questionnaire.
I've seen those questionnaires, and they're essentially like a 2-page questionnaire, and it's kind of quick to do. So for the member, or the family member, it might be easy, but then you have to give it to the teacher, and then the teacher fills it out, and then they combine the two. But yeah, I agree. Those can be helpful questionnaires, and they're not that hard to take. So I believe we can even just, basically print those offline.
Yes, they are available online.
So I think the next topic, or the final topic, will be what do we do once we diagnose the patient with attention deficit, and what types of treatments are available?
So there are several options for treatments. Classically, as you mentioned previously, some of the first treatments were stimulants. I think one of the first drugs that was available on the market was Ritalin. It's methylphenidate is the generic, and now today we have many more formulations that have been derived from the methylphenidate. It even comes in a patch form. I was just reading that recently, as of 2018, they've now come up with a nighttime methylphenidate that can help with like evening behaviors, helping the patient kind of calm down to get to sleep. It's very interesting, actually. It comes with a double-layered coating on the pill that extends the release of it, so it works over a full 24 hours. There's various other drugs that are like Focalin or Vyvanse are also other forms of stimulants that tend to be more long-acting. There are shorter-acting drugs such as Adderall. A lot of studies have shown that longer-acting drugs have less of a crash after when it wears off, and there's less reemergence of symptoms in the middle of the day, which can also help relieve some of the stigma, because now, the child or the adult is not having to step aside to take another pill, that someone might see them do that or know about their condition. There's also a drug called Strattera, which is a non-stimulant, and it works on the norepinephrine transporter systems in the brain, which targets similar to some of the stimulants. Most of the stimulants work on norepinephrine and dopamine, but Strattera doesn't come with that increased heart rate or some of the other side effects that can come with the stimulants.
Why wouldn't you choose that over the stimulants if you had the choice? Is it less effective?
Yes, it has been shown to be slightly less effective. It's considered a second-line drug.
And you mentioned to me one time that the one compounded treatment was better than the combo salts because they were hitting two receptors and causing maybe two possible side effects rather than just focusing on one receptor.
So the classic drug that comes in a form of a salt is Adderall. It does come in long-acting formulations, but most of it are short-term. And like you were saying, it targets multiple receptors in the brain because it's a less narrowly synthesized drug. So you're more likely to have some of those side effects than you would if you were to take a long-acting drug. Like, for example, Vyvanse is a prodrug, so it is the pre-metabolized form, and then it gets broken down. It's very targeted in the body.
Nice. And with the Focalin, because that's been a newer, like if you looked at it, I think Adderall, or Ritalin maybe was first, and then you had Adderall, then you had some of the newer ones like Concerta, Vyvanse, and I think Focalin basically was at the end of that. But there's a few formulations that you mentioned were patches, and then there's a liquid now for children. And how young can they start? My research was, I believe, 8 years old, but there are some children who as young as 6 can start it. But oftentimes, and it's different for different providers, but the recommendation is to avoid use of stimulants or medications until the age of 8. Although I've seen some younger kids do that because of their behavior was so severe and their symptoms were so severe that they were better off treated. I've seen also some off-label use of some medications as well.
Yes, you can use some drugs that fall into categories of tricyclics and SSRIs, which are classically used to treat like anxiety and depression type disorders. They can be used off-label. They just come with a little bit stricter of monitoring because they can come with slightly more side effects.
I remember a product, I think Guanfacine or Guanfacine or something like that. Guanfacine, not like the one that you get for cough, but I've had some patients on that medication for nighttime symptoms or later symptoms because it would help attention deficit, but it wasn't a stimulant. Have you heard of this?
Yes, I did.
Yeah. Do you remember the name?
It was like Guanfacine.
Yeah, Guanfacine. Yeah. I'm pretty sure that I think it has FDA approval for attention deficit, but it's definitely a secondary or a tertiary medication because it doesn't have a traditional mechanism of action. Mm-hmm. But it does help, and for some patients who maybe don't want to take a twice-a-day medication, they can use a stimulant in the morning and then use the Guanfacine in the evening. So, and we'll make sure that you guys know the exact name of that if that's not the correct name for it. But let's go ahead and talk about the summary or what your thoughts are in conclusion.
So, as previously mentioned, the worldwide statistics and the rate of diagnosis of ADHD and ADD can be 8 to 12%. Certainly that reporting scale can be slightly skewed depending on healthcare availabilities in certain areas, but it is a fairly common condition that is seen in childhood and adulthood. There has been some studies to show that in teens it can increase the likelihood of like car accidents and things like that due to impulse control. There's been some studies that show that teens with ADHD can be more likely to text and drive due to the impulse control. But overall, it is a condition that has multiple forms of management, anywhere from stimulant medication to non-stimulants to various forms of behavioral or cognitive therapy to kind of teach new ways of adjusting to the situations.
I think that there's no doubt in my mind that the patients that we see in our office who have been treated are doing better in school, their behavior is better, and I think adults are also who are being treated are having better relationships with their partners, and performance at work and in school is also improved. So I don't doubt that these medications have brought a better quality of life for patients. What about the side effects of the medications? What are some of the concerns for short-term and long-term?
So for stimulants in the short term, some of the most common side effects can be like slight increase in feelings of anxiety. It can give a slight anxiousness. It can increase your heart rate, decrease appetite. So monitoring weight is something that's very important in patients, especially young patients. You want to make sure they're not losing too much weight on their medications. And then in the long term, I think there have been some studies to show that there can be slight increased risk of cardiac events if it's taken for very long periods of time, especially in advanced age, just because it can increase the heart rate and the blood pressure.
Sure, and insomnia as well?
Yes. If the medication's taken too late in the day and it's not worn off soon enough before bedtime, it definitely can affect sleeping habits.
Excellent. I mean, you were very thorough with it. I can't think of any other questions. Do you have any final remarks that might help patients who are wondering if they should be, treated for attention deficit or if they have attention deficit?
I mean, I think everybody's situation is a little different. So I would say, talk to your provider, find out what works best for you, because it's not, certainly there's lots of medications and lots of options out there. So what works for somebody else or your friend or your neighbor might not work best for you. So I would say definitely just consult your provider.
Awesome. Thank you, Nikki, for a great podcast. We'll look forward to more podcasts in the future. This is Dr. Jonathan Youssef, Networking for Your Optimal Health.
Thank you.